Hello everybody and welcome to this video. We are here in Barcelona for the ESMO 2024. My name is Enrique Grande. I'm chairing the Medical Oncology Department at the MD Anderson Cancer Center in Madrid. I am very fortunate to be here with my colleague and friend, Dr Alison Birtle. Alison, where are you working in the UK?
So I'm Alison Birtle and I'm a consultant oncologist at the Rosemere Cancer Centre in Preston in the northwest of England.
And well, we are very fortunate to talk about bladder cancer, probably the most fancy tumor that we have today. What it has been presented in the metastatic setting?
So bladder cancer, you and I know that this is a Cinderella cancer where for many years we've had no drugs that have improved survival at all, going back 23 years. And so over the last few years, since 2020, we've had some new treatments coming through. And just to summarize those, what they've been was in 2020, we had the Javelin 100 study, which everybody is very familiar with, which is looking at giving patients who've had 4 to 6 cycles of platinum-based chemotherapy, maintenance immunotherapy every 2 weeks with avelumab, which had a 9-month approximately overall survival advantage. So we're all very familiar with that now. The second thing that we've been doing for a year, since ESMO last year, if we've got reimbursements, of course, is instead of chemotherapy, looking at the antibody drug conjugate enfortumab vedotin, which targets Nectin-4, and giving it in combination with pembrolizumab. So we know those data, even if we're not actually have access to those drugs because of reimbursement. So what's been new in that space with those drugs this year?
We have another alternative, the triplet.
We do indeed. We also have an interesting drug looking at targeting HER2 and looking at disitamab vedotin. And there was some data that was presented looking at that in a small number of patients at the moment. I have to say, the waterfall plot looks very exciting. It looks very active in these patients. And I was surprised about that because we've done studies in the UK. We did the LAM study, which was using lapatinib adjuvantly, targeting a very similar target. And that was negative. So interesting that it's looking positive in the metastatic setting. A long way to go because that was just a few patients in the study, but the response rates looked very good from the target lesions.
And I think this is a very good example to come here about the LAM trial, about the role of HER2 in bladder cancer. This is not a driver. This is just a marker. This is just, to select the tumors that you need to target, but not a good driver. Do you agree with me?
I think you're absolutely right. And the story in bladder cancer over the last few years, when we've had so much excitement originally about things like PD-L1, we thought we would be able to select what patients would we be able to treat, and they get a fantastic response with checkpoint inhibitors. What we now know is it's a prognostic. So if your PD-L1 is high, you're going to do better whether you have chemotherapy or whether you have a checkpoint inhibitor. And if your PD-L1 is low, whatever treatment you give, you're going to do less well. So all of these new targets that come through and markers, they're normally at the moment turning out to be more predictive of a response, except Nectin-4. Because the new data with EV pembro in combination, what we've seen was looking at low and high levels of Nectin-4 expression. This is the latest subgroup analysis from this juggernaut of a study. The other subgroups we've had so far were dividing into platinum fit, platinum unfit, upper and lower track. And surprise, surprise, like all of the other subgroups, it does not matter if your Nectin-4 is high or low. This drug conjugate antibody with your checkpoint inhibitor combination does work.
Exactly. So according to the data that Tom Bowles presented, well, we shouldn't change our practice. So our patients, regardless, as you mentioned, the location of the primary tumor, the expression of Nectin-4, should receive enfortumab vedotin. But these data are not really consistent with the German group retrospective data that we saw before, showing some differences in the expression in the primary tumor versus the metastasis. What do you think about?
I think we know that bladder cancer is one of those tumours that will acquire different mutations along the pathway. But one of the difficulties, Enrique, is that when you've got somebody with metastatic bladder cancer, it's not like some of the other cancers where you might have time to wait to do additional diagnostic biopsies on that patient to say what mutate, where along the pathway is that now in terms of their mutational tree. There are patients that we have to, say, give steroids to get them fit enough to have systemic chemotherapy. So does the standard oncologist in the community or in a busy practice have enough time to wait before they start treatment to do an additional targeted biopsy? And sometimes these are areas that are really difficult to reach. You know, they might be behind vascular structure, they might be bone metastases, and they're difficult to get. So I think in real terms, does it make a difference in terms of whether you've done a biopsy? Probably not, because you're going to go off what your original biopsy was, because you don't have time to wait for these patients, I think is the truth. Other thing about EV was there was a nice presentation looking at real world evidence from the Unite group.
The American experience.
And from real world experience, and what it looked at was response rate in those patients. And it was about 53% overall response rate with EV, so lower than the registration study of EV302. But that is sort of what you'd expect in real life, isn't it? Because the patients in real life are never going to be the same as when they're cherry-picked to go into a study of a new agent or a new combination.
Definitely. Comorbidities, dosing schedule adjustment, probably are influencing. Let's move to another option that we have, CheckMate901, the triplet of gem, cis, nivolumab. It is not impacting quality of life. What can you do about that?
So I think with any treatment, we want to make certain that patients' quality of life is maintained. And we know that the tools that we have in studies probably are slightly crude, aren't they, in terms of measuring genuine things that impact the patient, but they are what we live with. So it's reassuring to say that for patients who are cis eligible, giving triplet with gem, cis and evo, the quality of life is the same as whether you give gem, cis. I guess the thing would be, is that going to change people's clinical practice? Are people already adopting giving gem, cis and evo as part of standard of care? Because one of the uncertainties in my mind is when you look at the curves from the original study from 901, where you see the curves diverge the most, and the benefit is at that 6-month period. So it's probably the adjuvant part of the treatment. And is that very different from the original Javelin 100 data, where because that came out earlier, we're all very comfortable with giving chemo switch for those patients at 4 to 6 cycles. And I think in the future, it may be that studies that are ongoing, like Tom Poles' DISCUS study in the UK, randomizing patients to stop chemotherapy at 3 cycles, maybe that might be better in terms of efficacy. See, there are obviously people who are really enthusiastic about the triplet. I'm less so, and so therefore for me the quality of life data is reassuring, but not for me, for those people that choose to use that. The thing that I was the most happy about, and I go home today, and so I'm doing clinic tomorrow. For the patients that come into my clinic tomorrow that are on maintenance avelumab, I've new things that I can tell them that will just reassure them, because this was looking at some further analysis of Javelin 100 and looking at conditional survival. So if you're a patient who has had a year's worth of maintenance avelumab, it was showing what your chance of being alive a further 6, 12, 18, 24 months down the line was. And the results were really good. We were looking at more than 85% survival for some of these patients at 18 months and 2 years. And then if you got to 2 years of treatment, it was even better. And that was about 20% of patients in Javelin 100 had been on treatment for 2 years or more. So it then looked at what their chance of being alive was. And I can tell my patients that tomorrow. So that helps them in terms of planning for the future, because many of our patients, we're used to dealing with this as a lethal disease with survival 8 to 14 months with chemotherapy. So being able to tell them these things, I couldn't have believed a few years ago that we would have life-changing drugs that maintain quality of life and improve survival in patients. And we've got 2, I think, great choices in the first-line setting. We've got the combination of EV Pembro, we've got platinum-based chemotherapy, and then looking at switch maintenance to avelumab, or if you're an enthusiast, you could use gem, cis and evo. But we've got options for patients, and you choose the right combination for the patient that's in front of you in the clinic, and some may be suitable for one, some for the other.
Absolutely. So we have a lot of good news in the field. Not such exciting ESMO last year that we have the 2 phase 3 trials up and running, but I think the data are pretty consistent, are reinforcing how we are treating our patients, are giving us more tools to analyze the options that we have. So I'm delighted. I've been delighted to be here with you, Alison. It was amazing to have this talk.
Thank you very much. It was a pleasure.
Thank you. Thank you all. And well, I invite you to go for the next video.